A smaller wound near an eyelid, nostril, or lip can be more complex than a broad, shallow wound because function matters more than surface area. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. Welcome to this explainer on large flaps and complex Mohs reconstruction.
When we talk about complex reconstruction, you have to realize that a small wound crossing a really vital free edge, like your eyelid or your lip, requires immense precision. It's not just about the size. Surface measurements alone just don't tell the whole story. They don't reveal the missing structural support or how tension is going to pull on those delicate areas.
And that core mission we just mentioned, that is exactly why we're here today. We are relying entirely on that meticulously reviewed evidence to help you understand exactly how surgeons navigate these really critical and sometimes daunting reconstructive choices.
Okay, let's dive right into our roadmap for today. First, defining reconstructive complexity. Second, the decision pathway. Third, choosing the operative setting. Fourth, the clinical evidence. And finally, your specific recovery plan.
Section 1. Defining reconstructive complexity.
Before any tissue is ever rearranged, the absolute golden rule in dermatologic surgery is confirming complete cancer clearance, using the precise Mohs map. You definitely don't want to move a large flap over an incompletely assessed margin. Now, complexity isn't just about how big a wound is. The reconstructive team looks deep into the wound and asks, are we lacking fat, muscle, or cartilage here? They carefully evaluate high-stakes anatomy to protect your eyelids, nostrils, and lips. They're mapping out limited skin movement, figuring out the blood supply, and calculating safe tension levels. And crucially, they have to weigh the patient's overall health and staging needs. The complexity of a surgery really has to earn its place by solving a specific structural problem.
Section 2. The decision pathway.
A large flap is really just one way to reconstruct a wound, right? It's not a quality score. Let's take a look at the diverse reconstructive tool belt a surgeon actually uses, because a flap isn't always the best choice. Surgeons carefully weigh their options based on specific anatomical trade-offs. For instance, direct closure brings mobile wound edges together, but it might require a longer scar line just to distribute tension safely. A local flap recruits nearby skin and redirects that tension away from vulnerable anatomy, but it means more incisions and requires some serious vascular planning. Then you have a skin graft, which covers the surface efficiently without moving nearby tissue, though you might trade off an exact color, thickness, or contour match. Finally, there's second intention, which is just natural healing. This relies on the body's natural filling process, meaning you'll have a longer visible healing time and some site contraction.
And if those first options just aren't cutting it, the pathway expands. A staged flap brings in durable tissue in planned steps. It's highly reliable, but the trade-off? Well, you're looking at a temporary tissue bridge and an extra procedure. A delayed repair allows for selective planning or preparing the graft bed, which means a temporary open wound period. Finally, collaboration. Sometimes the absolute best decision is to bring in another reconstructive specialist to add microsurgical capabilities, deeper anesthesia, or even a hospital setting. Ultimately, the best repair is always the least burdensome option that reliably protects your function and contour.
Section 3. Choosing the operative setting. Let's see how the choice of where the surgery happens builds directly on the patient's specific needs. The available evidence actually supports both outpatient and hospital settings, but it doesn't prove one is universally superior to the other. Many complex repairs happen completely safely right in an outpatient office when the patient is medically stable, under local anesthesia, and has manageable bleeding and pain. However, an ambulatory center or a full hospital becomes absolutely necessary if you need airway support, general anesthesia, extensive framework repair, or if there's a severe medical risk involved.
Section 4. The clinical evidence.
The crucial point here is understanding what the observational data actually proves, while strictly respecting the boundaries of the research. Claims that one setting is always safer go way beyond what the data actually says. Let's start with this big number. 20,821. A prospective multi-center cohort of over 20,000 Mohs cases reported a low overall adverse event rate, but context is absolutely critical here. Remember, this reflects the entire full case mix. You cannot just take this low rate and use it as the complication estimate for every large flap.
Similarly, we have a single-center series of 653 selected staged flaps that showed no major complications in an outpatient dermatologic surgery setting. That sounds amazing, right? But once again, we have to look at the boundaries of the study. Strict patient selection and profound surgeon experience limit us from generalizing this to everyone. It proves feasibility for a very specific group, not a universal guarantee.
Finally, a 2025 academic cohort looked specifically at 436 large post-Mohs repairs performed under local anesthesia. Now, no adverse effects were attributed to the anesthetic itself, but the overall complication rate was 16.1%, which definitely exceeded the rate for smaller repairs. So, what's the useful takeaway here? It proves that selected large repairs are indeed feasible in an office under local anesthesia, but they are absolutely not routine small closures.
Section 5. Your specific recovery plan.
We now shift our focus from the surgical decision-making to your vital role during the recovery process. A large reconstruction can look and feel quite different early in the healing process than it will down the road. Because every flap, graft, and anatomical site is totally unique, you must strictly follow the detailed recovery and contact plan written specifically for your actual operation by your treating team. Please completely avoid generic online wound care checklists. Detailed guidance on swelling, wound care, and exactly who to call if there's an unexpected event belongs exclusively in the instructions generated for your specific repair.
Healing takes profound patience. In the early healing phase, it's really just about settling the swelling and forming that initial early scar. But for months after, the appearance often continues to change as the scar matures. In fact, that 2025 data we mentioned shows that aesthetic satisfaction and patient-reported quality of life can continue to improve for at least 1 full year after Mohs surgery. Now, no study can predict exactly how an individual scar will heal, but knowing this timeline really helps manage expectations.
Before any complex repair, empower yourself by asking your surgeon this exact question. What function or landmark is the plan protecting? Remember, complexity only adds value when it solves a structural problem that a simpler option cannot. So partner with your treating team, have that open conversation, and keep asking the right questions. Ultimately, if the main goal of the surgery is to clear the cancer, how much further can reconstructive science go to completely restore not just the skin, but the vital functions of our face? Thanks so much for joining us on this explainer.